Good afternoon, everyone. My name is Maya Luria with TMC for Seniors, and we are continuing on with our survivorship series, and we're going to be talking about understanding your options navigating breast cancer care. I have Dr. Rebecca Viscusi here with me. She is with our TMC Health Cancer Center. How are you today, Dr. Viscusi?
I'm fine, thank you.
Great. So, I know you have a lot of information to share. I'm going to go ahead and put your PowerPoint up for you so that you can see it. You do have an online audience that's watching today, along with an in-person audience. So if you've got a question for Dr. Viscusi, please go ahead and enter those into the chat, and I'll address those afterwards. I'll turn it over to you, Dr. Viscusi.
Thank you. Hi, how is everybody? Hope everyone's doing okay. And like I said, this doesn't have to be a formal thing. If there's any questions while I'm talking, just raise your hand and I'll call on you and I can answer questions while we're going. Don't have to worry about interrupting me. And again, same thing. I kind of going off the title of the talk, tried to put in stuff about, again, what it means to be diagnosed with breast cancer and the different treatment options that are available. But we can, go in any direction that anybody wants to go. We don't have to follow exactly what I have. So sort of my objectives that I was wanting to talk about during the talk were just to discuss, like I said, breast cancer in general, so the biology of the disease and some risk factors associated with it, talk about how breast cancer is usually diagnosed, and then talk about the management and treatment options that we have available. So breast cancer is a very common disease, unfortunately. So these are the numbers from the American Cancer Society. You can see over 300,000 women are going to be diagnosed with breast cancer in 2025 alone. The good news is that the number of deaths are going down. So we're getting really good at, we've been good for a while, but we have really good ways of treating breast cancer. And so the good news is that we're catching it early. And it's very treatable, and we have good ways of treating it. And so the rates of death are going down, which is fantastic. So the average risk of a woman in the U.S. developing breast cancer is 13%. So that's 1 in 8 women. So it's a lot. It is the second leading cause of cancer death in women, second to lung cancer. But again, like I said, the death rates have been decreasing steadily since the 80s, and the chance that a woman will actually die from their disease is about 2.5%. So it's we are, like I said, we are getting good at what we do, and as I was saying, some of it is that we have better ways of screening. We're catching the disease earlier. There's increased awareness. We're talking about it now more than we used to talk about it in the past, and we have better ways of treating things as well. Treating the disease as well. And so, what are the risk factors? And this gets a little bit tricky because you could read 5 different articles and you're going to hear 5 different opinions of things that you need to change and things that you need to do. But just to sort of break it down, the way that I see it is that, the risk factors can be broken down into things that you can change. So things that are lifestyle related versus things that you can't change. And so drinking alcohol, being overweight, those are sort of 2 of the big ones, which I know is hard because we all occasionally like our alcohol. But we do know that drinking alcohol is linked to an increased risk of developing breast cancer. And it goes up with the amount of alcohol consumed. So women who have 1 alcoholic drink a day may have a small increase in the risk. And so that's not necessarily a huge deal. We're talking more about women who are having 2 to 5 drinks a day, that kind of thing. So it's just something to think about. The other, again, is being overweight. And so being overweight after menopause does increase your risk. Before we go through menopause, our ovaries are what are making most of our estrogen. And then once we go through menopause and our ovaries stop making estrogen, most of our estrogen comes from our fat cells. So having more fat after menopause can raise the amount of estrogen in your body, which can potentially increase your risk of developing breast cancer down the road. So again, just something to think about because those are things that we could potentially change. Some of this other stuff, the thought is that being pregnant and breastfeeding can be somewhat protective, can be somewhat protective. Sorry, somewhat protective. And in general, they sort of the idea is that it reduces the overall number of menstrual cycles in a woman's lifetime, and so that is what is protective about it. So the thought is that women who have never had a full-term pregnancy or had their full-term pregnancy after the age of 30 can have an increased risk. Again, breastfeeding is somewhat protective, can potentially lower the risk, but it's not absolute. So I see women who have 5 children who have breastfed, each one of them for a year and still get breast cancer, and then we also have the opposite, women who have never been pregnant, have never breastfeed, who never get breast cancer. So it's not an absolute risk. Oral contraceptives, so birth control pills. There's some mixed information in the literature about that. But I think the thought is that as you get older, it tends to increase your risk. So, women in their 30s and 40s who are still using birth control, that can increase their risk for getting breast cancer. And then the other big one is the estrogen replacement. And so I know that's hard because, we like our estrogen, and for a lot of people, a lot of women, it's hard to not want to take estrogen. But from a breast cancer standpoint, we do know that it increases the risk of getting breast cancer. And when we talk about hormone replacement, there's two main ways that we talk about it. Let me go back. 2 main ways that we talk about it. So we have combination hormone replacement. So that's both estrogen and progesterone together. And then we have estrogen only hormone replacement. It's mainly the combination one that increases the risk the most. So that with the combination of the estrogen and the progesterone together, it can increase a woman's risk by about 75%. So it's a pretty big number. Yes.
Okay, so that's really frustrating.
I know.
Really frustrating because I was really poo-pooed about that 2.5 years ago. And I was told that information had been debunked, and I started hormone replacement and have now had breast cancer. And I even in asking all of my doctors, is it potentially related? Well, we don't know. But you're saying 75%? That's completely different than the data I've been given.
Yeah, and that's why I sort of prefaced in the beginning, that's a little bit challenging because there's so much data out there and it's hard to know what to believe. And so, and to be honest, I don't 100% remember where I got that 75% number from. And so that could be a mistake on my part too, but it definitely, from a breast cancer perspective, it definitely increases your risk of getting breast cancer. And the other thing, and again, this is more anecdotal more than anything, is that, in what I was reading, they commented about how, once you stop the hormone replacement, like after, 2 or 3 years, your risk starts going back down, and it can get back down to the same as somebody who hasn't been on HRT before. But again, doing what I do, I see women who come in who have been off of it for 10 years and have breast cancer, and it's their only risk factor. So it's still a possibility. And so I think it's hard because there's a lot that we don't know, and there's a lot of conflicting data because the pendulum swings in a lot of different directions. And if you talk to, a cardiologist or whatever, they might say something totally different because we know that estrogen, well, I take that back. But if you speak with other physicians, you might hear something different in terms of that. We know that there are some benefits of taking hormone replacement, but from a breast cancer surgeon perspective, it does increase your risk of getting breast cancer.
Right, and that was exactly it. It was a rheumatologist who really,
right,
because of
your bone health.
Yeah.
Right.
So but I was really concerned about breast cancer, and he completely.
I'm sorry.
Yeah.
I'm sorry.
That's all right. No, that's
Sorry.
It kind of validated for me
what you knew all along,
Yeah,
right?
exactly.
Yes. And it's hard because, like I said, the estrogen, going through menopause is difficult. Losing estrogen is hard. You feel way better when you're on the estrogen. But there's risk, and there's how do I want to say this? Like pros and cons in terms of you have to figure out what's best for you. Like I do know women who have very, very debilitating menopause type symptoms, and the quality of life is way more important to them. And they know that there's risks for taking the estrogen, and they want to continue to take it even after being diagnosed with breast cancer. So it's hard, and you just sort of have to figure out what works best for you. But from my perspective, I personally would stay away from it. Yes, let me put it that way. Yes?
Does that mean that as you age and have less estrogen, you have less chance of?
No, unfortunately. Your fat cells, right? So you get estrogen from other places. You can get estrogen from your adrenal glands. You can also get estrogen from your fat cells. So so unfortunately, even though you go through menopause, your ovaries aren't producing estrogen, it still puts you up. You can still be at a risk for getting breast cancer. And it's also confusing too, because it's not a snapshot of your current estrogen status. Does that make sense? So like if somebody has an estrogen sensitive breast cancer, it doesn't mean that they have high levels of estrogen and that's why they got it. It has to do more with your lifetime exposure to estrogen. So like on you'll see on this slide, like we talk about early menarche and late menopause. So again, that's not anything you can change, but the idea is that if you started your period early or you went through menopause late, that you're being exposed to estrogen longer than somebody who has had a late menarche and an early menopause. Yeah.
Is there a way to measure, if you have ER positive and PR positive or one or the other, is there a way to measure what your estrogen levels are? So
yes, there's a way to measure your estrogen levels through blood work, but it doesn't correlate with the cancer. Does that make sense?
No.
So because again, it's not a snapshot in time of what your estrogen levels are. Right. And it has to do, like getting breast cancer in general is sort of multifactorial. So there's a lot of reasons that go into it, and the estrogen is just one part of it. And so, yes, you can check your estradiol and FSH and LH levels, but that there hasn't been shown to be a correlation in terms of treatment of cancer as far as that goes. Does that make sense?
Yeah.
Sort of. Okay, so that's the HRT. And then the other thing that I like to talk, so there's two other aspects about the hormone replacement. So one, sometimes people will ask me about bioidentical. Is it okay to take a bioidentical form? It's the same thing. So even though they call it bioidentical, it's still an estrogen. And so it can still increase your risk. And then the other part of it is vaginal estrogen. So vaginal estrogen, the amount that gets absorbed is very minimal. And so that does not increase your risk of getting breast cancer. We use that a lot. It's even in women who have breast cancer to help with vaginal dryness. So vaginal estrogen is fine. But again, we generally, as a breast surgeon, recommend staying away from oral versions of the hormone replacements. Okay, so those are the risk factors. So in terms of diagnosis, so when we talk about imaging for the breast, there are a couple different modalities of imaging that we use. So we have mammogram, we have ultrasound, we have MRI. The mammogram, I'll talk about screening versus diagnostic in a second. And then I also have a slide about 2D versus 3D. So we'll talk about that too. But when we talk about mammogram, there's two views. So the two views are what we call MLO and CC. So CC stands for craniocaudal, and that's the one where they're smushing your breast from head to toe. And then we have the MLOs, medial, lateral, oblique, and that's where the breast gets compressed medial to lateral with a little bit of an up angle to get up under the pec muscle. Yes, ma'am.
I was wondering about the other risk factors that you didn't go over.
I was trying to just push by that. No, I'm just kidding. Yes, ma'am. What was your question?
Well, there's a number of them on the second section there.
Yes. Yeah. So the idea is that these are things that you couldn't necessarily change. So, being a woman puts you at a risk for getting cancer. Getting older puts you at a risk for getting cancer. Like I was saying, the early menarche and the late menopause has to do with lifetime exposure to estrogen. We also have genetic risk factors as well. So family history of breast cancer, family history of a genetic mutation. There are certain benign breast conditions that can predispose somebody to cancer. There's, and I didn't go too much into it in the rest of the talk, but there's something called atypical ductal hyperplasia, or atypical lobular hyperplasia, that if that's diagnosed on a biopsy, then that means that you're at a higher risk for getting breast cancer down the road. And then in terms of the last two spots on that, so prior chest radiation, so, they used to treat Hodgkin's lymphoma with radiation to the chest, and we now know that those women are at increased risk for getting breast cancer just in the radiation field because they were being treated when they were young in age. And then DES, so women who took DES or children of mothers who took DES, they are also at an increased risk for getting breast cancer as well.
What is DES?
DES is, oh, I thought I wrote it down. Yes, thank you. Will you say it one more time? Yes. So it was a drug that I want to say, what was it, like in the 50s, maybe 60s, that was supposed to help prevent miscarriages. But we now know that it's associated with breast cancer, either if you took it or if your mom took it.
When you say prior chest radiation, they have a time frame for that?
I'm sure there is at some point. At least what I specifically was talking about was the young women who got it for the lymphoma. I feel like I had this written down. Oh, sure. Was there a time frame in terms of the radiation? And so I don't know. So at least in my reading about it, what I had written down was that it varies based off the age. So the risk of developing breast cancer from radiation is highest if you had radiation during your adolescence. So while you were still developing, as far as your breasts were concerned.
And did you say Hodgkin's or non-Hodgkin's?
It was both, I believe. But I don't necessarily know that they are doing that for the treatment. And again, it's a little bit out of my wheelhouse because I don't treat it, but I know that was part of the treatment before, and I'm not sure that they do it as often now. Was there any other, I tried to blow past this, but was there any other questions about the risk factor part? It's just hard. It's hard because, again, like I said, you can read five scientific articles and they're all going to say something different. So it's really hard to know what to do, I guess, nowadays with all the information that we have in our face. Okay, so back to diagnosis. So again, imaging modalities. So we talked about that. So the two views, so the CC and the MLO. And then when we talk about mammograms, we also talk about them screening versus diagnostic. And so a screening mammogram is where a woman goes in and gets the two views. So you get the CC and the MLO view, and then you leave and you get either a phone call saying you need to come back, or you get a letter in the mail saying everything looks fine. The diagnostic is where the radiologists actually have the ability to do additional imaging. So they can potentially do what's called spot compression, which I have a picture of, which is magnification views in the area, and then also the ability to do an ultrasound. And so the reason why I like to bring this up is because if you are experiencing any problems, it's better to go in for a diagnostic mammogram. So that way they have the ability to do the spot compression and do the ultrasound while you're there, as opposed to you leaving and having to come back. So it's important if you go see your primary and you say, hey, I'm feeling something, that you make sure that they order a diagnostic mammogram. Yes?
If you have an MRI right before you have a mammogram, do you really need the diagnostic?
So technically, yes. And the reason why is because there's things that can show up on the MRI, that show up on the mammogram that don't show up on the MRI, and vice versa. So they're sort of, we like to use them in conjunction with each other. Mammograms aren't perfect. So you'll see, 10% false negative rate. So there is a possibility that it could miss something. And the denser your breast tissue is, the harder the mammograms, the sort of less effective the mammograms are, because sometimes it's hard to see through that breast tissue with the mammogram, the dense breast tissue.
Are they doing any of that? I know in Europe and in the UK, they're doing sort of the with and without contrast for dense breasts. Are we starting to see that here yet?
Not in Tucson yet. To be honest, I think that there's a place in Phoenix, but I'm not 100% sure, but not in Tucson as of yet. And I think some of that is it has not been completely validated. And so again, as I brought up before, so the diagnostic, the radiologist will look at it before you leave. You can get the results before you actually get out of there, and it gives them the ability to do additional imaging if they need to. So how we classify the mammograms is off of what we call the BI-RAD system. So the BI-RAD system is through the American College of Radiology. It stands for the Breast Imaging Reporting and Data System. And this is a way for the radiologists to standardize how they're reading the mammograms. And there's actually, I know the picture only has 5 numbers, but there's actually a total of 6. And so the idea is that I can look at a mammogram and see what the radiologist classified its BI-RADs as to know how significant what I'm looking at is. Does that make sense? So something that's a 1 or a 2 is not anything that we usually worry about. A BI-RADS 3 generally needs additional imaging or ultrasound, and then a 4 and a 5 are the not so great ones. And then there's also what's called a BI-RADS 6. So like if we know somebody has a biopsy, a proven breast cancer, and they go in to get an MRI for, preoperative purposes, that's usually called a BI-RADS 6 because we know they have a cancer. And so 3D versus 2D, that's another sort of big talk or a big thing that people like to hear about. It's just like what it sounds. So 2D is 2-dimensional. So it's just a static image of the mammogram versus a 3D, which is 3-dimensional. And what it actually is that they're taking slices through the breast. And so this got approved in 2011. You're looking at the breast in 10 to 15 1-millimeter slices. So the idea is that it helps the radiologist see through that breast tissue better than a 2-dimensional mammogram. And because it can kind of see through that breast tissue a little bit better, it has less callbacks. So that's what when we say a reduction in false positive recalls, that means that again you go in for screening and they call you back for a diagnostic. There's less of that with the 3D, and then it also has a higher cancer detection rate as well. Most of the places in Tucson are doing 3D mammograms. And so if you go to go get a mammogram, the majority of the time you're getting a 3D without even knowing it. It is the better mammogram to do. It used to be that it cost more. So I had patients complain that they had to pay a higher copay for it. I haven't heard that in a while.
What about the radiation?
It's the same. It's the same. So the radiation from the mammogram from either one of the mammograms is very minimal. And plus, I shouldn't say it like that. It's very minimal.
3D is screening.
Yes. Yeah, it can be used for both. So you could have a 3D, both screening and diagnostic. Does that make sense?
Does the patient ask for the diagnostic?
Sometimes, not as much as it used to be. Because like I said, it's become more of the standard of care. And so the majority of the places just do it because we know it's a better test. That being said, I don't know that every single mammogram facility in Tucson has switched over, but the majority of the big ones have. So most of the time you don't need to ask, but if you wanted to, you could double check to make sure that yes, that's what you're getting. And yes, it's for both screening and for diagnostic. Okay, so that was 3D versus 2D. And then the other really confusing part is the recommendations. I have that somewhere. So, and again, this is also another one of those things that's constantly changing.
Sorry,
It's okay.
can I just ask a question about
Yeah.
the diagnostic versus screening? If you've been diagnosed, if you are high risk and you have breast cancer, does your doctor usually order a diagnostic screening?
So generally, what the radiologists usually recommend is to do diagnostic for the first couple mammograms after you've been diagnosed. So usually for the first 2 or 3 years, we'll do diagnostic and then go back to screening after that. But I also let my patients decide some of that too. So, because there's some patients who really like the idea of knowing that the mammogram looks fine before they go home instead of waiting for the letter. So if I have a patient who tells me that they would prefer to do a diagnostic, then we do that for as long as they want.
So it's up to you to actually ask your doctor if that's what you need.
Yeah, yes, correct. So most of the time they're ordering screening mammograms.
Okay, thank you.
Yes. But if you're in the care, like if you're being followed by a breast surgeon or you're being followed by a medical oncologist, most of the time you'll get a diagnostic, at least in that first couple years. Okay, so screening. So again, this is the other controversial topic. There's something that's called the United States Preventative Services Task Force that puts together recommendations in terms of medical treatment, and I'm sure they do other stuff as well. But that's kind of the go-to for a lot of the primary care physicians in terms of recommendations of what to do for screening purposes. And so in 2009, they released screening guidelines that showed, you'll see on the top, that they were recommending that you don't start screening mammograms until the age of 50, and that you do them every other year instead of every year, with sort of insufficient evidence to recommend doing them over the age of 75. The reason why they said that was because there's a much higher false positive rate in younger women because they have denser breast tissue. And again, like we said, the mammograms can be harder to read if you have denser breast tissue. So even though they found that there was a reduction in breast cancer mortality by starting screening at a young age because of the false positive rate, they felt like they needed to say you should wait until you're 50. That being said, if there was a lot of disagreement about that through, American Cancer Society and the NCCN and the breast surgeons and the radiologists, everybody disagreed with it. Just within the last year, the U.S. Preventative Task Force has actually changed their policy. So now they say, yes, you should start at 40, but they're still saying that every other year instead of every year. But again, if you look at, so on the bottom of that list, you'll see NCCN. So NCCN stands for National Comprehensive Cancer Network. That's where, again, as a breast surgeon and a medical oncologist and a radiation oncologist, we get most of our guidelines in terms of treatment. And so if you look at their recommendations, it's to start at the age of 40 and to do every year instead of every other year. And I'll talk about the over 75 in a second. And same, ASBS stands for American Society of Breast Surgeons. And so again, same thing through American Society of Breast Surgeons. The recommendation is to start at 40 and to do every year, not every other year. Once you get over the age of 75, again, that gets a little bit tricky. So most of the recommendations talk about that, you should do it up until your life expectancy is less than 10 years. That's right. Yeah. Like, that's hard. Like, how do you know? Nobody knows what their life expectancy is going to be. So my rule of thumb and my philosophy in all of this is that, if you had a mammogram and they told you got diagnosed with a breast cancer on the mammogram, if you were willing to still do treatment, then you should still be getting mammograms. If you get to the point where you're like, no, if somebody told me I had a breast cancer, I wouldn't do anything about it anyways, well, then you can stop getting mammograms. There's no point.
So what's going to happen to you?
Well, that's the tricky part. No. I wouldn't say that. So it's hard because again, that whole also goes back to the crystal ball, not knowing how long your life expectancy is, right? So breast cancers are all different, and so sometimes we have slow-growing breast cancers, sometimes we have fast-growing breast cancers, and so it's again, it's all a personal. I think it's a very personal decision, is where I'm coming with all of this. So we can have all of these guidelines, but in reality, it's really up to you and to decide if you want to continue doing mammograms or not. Like, you could be 90 and say, why would I not get a mammogram and still get mammograms? Does that make sense? So I think, it's tricky because there's varying degrees of information that is out there. But I think if you talk to most physicians who treat breast cancer, they're going to say pretty much the same thing, that if you're willing to be treated, then you should still be getting mammograms.
Be the squeaky wheel.
Be the squeaky wheel.
Be the squeaky wheel.
Yep, and that I have more about that too. So
I have a question.
Yeah.
About if you have daughters and lots of female relatives,
Oh.
what is screening recommendation for them, or how should they be appraised of?
Sure. And again, the average risk. So generally, we recommend starting at 40 for average risk women. But if you have a significant family history, you're probably at higher risk. And so again, you'll see different things. Most of the time, they say start at the age of 35 or 10 years younger than the youngest person in your family. So if you had somebody in your family that was diagnosed at 40, then we would recommend starting at 30. The other part to that too, like you'll see on the slide, is we also recommend getting MRIs in addition to the mammograms. Because again, especially in young women, breast tissue is dense. The MRI supplements the mammogram to make sure we're seeing through that breast tissue well. Yes.
So with the super duper ultra dense breasts, young women, what do you recommend?
An MRI. So usually,
What age?
so 35 or again, 10 years before the youngest person in the family. And that's not including a genetic mutation. So if somebody has a known genetic mutation, then we might start earlier. We might start at 30 instead of 35. But yeah, but to go back to your question before, is that the mammogram can pick up stuff that the MRI doesn't, like calcifications. MRI is not good at finding calcifications, but mammograms are. So that's why we still recommend doing both. And usually what we'll do is we'll alternate it, so you're getting one every 6 months. So mammogram once a year, MRI once a year, but one of them every 6 months.
The MRI pick up very well?
The MRI picks up smaller things. And it sees through like the density a little bit easier. So it's able to pick it up smaller and earlier than a mammogram would be. But again, a mammogram is still important. I know it's counterintuitive, and a lot of patients are like, why am I still getting mammograms? They're still important. Mammograms are important. Okay. Any other questions about that? You guys are full of questions. I love it. I love it. Okay. So that was about the diagnosis. And so now we go to the what if they find something. So again, let's say you go in, you get your screening mammogram. This is an example of a screening mammogram. So you go in, you get your screening mammogram, and lo and behold, you get a phone call that they say, oh, we would like you to come back for additional imaging. So if they see something on a screening mammogram, you get called back for a diagnostic mammogram. This is an example of a mass that was seen on a screening mammogram. This is not a good picture. I'm sorry it turned out so poorly. But this is what's called spot compression. So when you come back in for your diagnostic mammogram, what they will do is they will do magnification views or cone down views at the area of concern. And because again, with a mammogram, you could have overlapping breast tissue that looks like a mass. And so by compressing that further than a regular mammogram and magnifying in that area, you can tell, is this something that's real, or is it just overlapping breast tissue that compresses out? So you go back in, you get your spot compression, and then you usually get an ultrasound as well. And so an ultrasound is used in conjunction with the mammogram. Same thing, we usually don't use it by itself. We use it together with a mammogram. And the idea is that it helps differentiate cystic versus solid. So it gives us a little bit of a better picture of what we're looking at. Is it a solid mass? Is it a fluid-filled cyst? What does it look like? And then we also have the breast MRI. And I didn't talk a huge amount about the breast. I know, right? You just look at that picture and you're like, oh my God. And that's partly why I like to put the picture there so that you can see. Like for a long time, I was at the university and taught residents and medical students, and you talk about ordering tests for people, but you don't really understand what you're asking them to do if you don't know what it looks like. And so I just like to put the picture out there so you can see, if you haven't had one, this is what it looks like. It's very uncomfortable. Yes. But again, well, here, this is what it looks like. So the idea is that it doesn't use any radiation. It's based off of a magnet. It doesn't use CT contrast, it doesn't use an IV contrast, like an IV dye, like a CT does. It uses what's called gadolinium. So you still get an IV, and you still get gadolinium, an injection of gadolinium. But what it gives us is this really pretty picture. So there's ways to color code it through the MRI. So it really shows the it really shows the tumor very well. So the advantages of getting an MRI are just like I said, is there's no radiation associated with it. It doesn't matter how dense your breasts are because it sees through the breast tissue better than the mammogram does. So it allows us to localize and characterize the cancer a little bit better, and make sure that there's not additional disease in that breast or the other breast. Yes, ma'am.
Just to alleviate somebody's anxiety, I get breast MRIs done regularly because I'm a breast cancer survivor. And I find that they're actually not that bad because you're face down. If you're claustrophobic and you're looking up at the thing, it may affect you differently, but face down, I find it very comfortable. And I used to not like MRIs, but I tolerate it very well. I don't have to take anything anymore. It's really not really that bad.
Yeah.
You're not a big squeeze. right?
No. No. Yeah, your breasts are hanging into a hole, essentially, as a whole. Yeah, yes, yes.
Because the first one I had was so excruciating, the second one I said, I couldn't breathe.
Uh-huh. It fixed it.
Accommodated me by putting extra stuff.
It's perfect. That's perfect. Yeah, yes. And they are, the technologists that are at the places are very cognizant of the fact that it's not the most pleasant test. And so they are very willing to help. They play music, they'll talk you through it. So they are there to help you. Okay. But just like we said, disadvantages. So disadvantages are just like what you're hearing. So one, it's an expensive test. Two, it's the positioning is somewhat uncomfortable. It is an MRI, so you are in somewhat of an enclosed, you're in somewhat more of a tube-like structure, but it's still open on the front and the back. It's just not completely open like the CT scan is. So if you're claustrophobic, that could be an issue. If you have metal in your body, that can be an issue. And then the other big thing is the false positivity. So again, because it is a more sensitive test, there's a higher chance that they're going to see something that's going to lead to needing another biopsy or needing additional imaging that might not have needed it to begin with. So that's, again, another disadvantage of the MRI. The MRI, not everybody needs an MRI. I had a slide in there about when I would get MRIs and when I wouldn't, and I took it out. I should have just left it, but not everybody needs an MRI. So for a cancer diagnosis, if I am seeing a patient in clinic with a brand new cancer diagnosis, if they have dense breast tissue or if they have confusing mammogram, like if the mammogram, like let's say, the mammogram showed one mass, they got an ultrasound, the ultrasound showed 3 clustered together. So that doesn't necessarily fit 100%. So I might get an MRI to give me better characterization of the area. So dense breasts, confusing imaging, in a new diagnosis, I would get an MRI. We do a lot of MRIs for follow-up as well. Again, if you have a personal history of breast cancer and you have dense breast tissue, we'll use MRIs to follow you in addition to the mammograms. And then we also use it for women that have genetic mutations or big, strong family histories, that kind of stuff as well. Yeah.
Thermography, would you about that?
I think thermography is fine as an adjunct to everything, but I don't think it should be the primary modality of imaging. I don't think it's good enough to be the only thing that we rely on. But I also think that something is better than nothing. And so I have had instances where I've had patients who said, I'm willing to do an MRI, but I'm not willing to do a mammogram. I'll do the MRI and I'll supplement it with the thermogram, and we've done it that way, but it's not my first choice. Yeah.
Who should you be followed by after your surgery?
So depends on who you talk to. Me personally, so for sure the medical oncologist, well, I guess I shouldn't say for sure. If you are being treated by a medical oncologist, then yes, you should continue to follow with them. I like to continue to follow my patients after the surgery. Usually I'll follow them at least for a couple years because I tend to be the one that does their breast exam and orders their imaging, but not all the breast surgeons in town do that. So most of the follow-up is the medical oncologist. Yeah.
My example, I had breast dense tissue on mammograms for over the years, and then there was a group thing, and alternating like you do for your patients.
breast MRI once a year, every, 6 months apart. And I find that I'm getting opposite result from radiologist, and all of a sudden I don't have dense tissue on the mammogram, but I do have my MR report that says I do have dense tissue. There's this.
Yeah.
But this last one that I did in January, the technologist that did the MR did a more lengthy one, which then gave a more scary Brad's 4.
Uh-huh.
So I went from a 1 to a 4, and then I had all the dialogue, and it is very stressful because I know the radiologist place is the one that determines the length of the MR. They used to do like less than 10 minutes. And
Yeah.
that was 20, and then I got all these frightening results and still in chaos because then I had another mammogram, and then it shows, oh, nothing's wrong, and then I had another, and then it's very.
It's a lot,
so
yeah.
The longer you're in an MIR tunnel or whatever you call it, can skew results.
No, not necessarily. They have.
The average time.
So, and again, it gets a little bit complicated. So, like, if it's your very first MRI, that one tends to be the longest. And then once they kind of have an idea, I think, so let me back up. They have what's called an abbreviated version. And so the idea of the abbreviated version is that it's somebody who, a big thing with MRIs is that you're comparing old to new. And so if somebody has had an MRI and we know, and they have something to compare it to, and it's more for screening as opposed for characterizing the cancer, then sometimes they'll go to the abbreviated version. So why they switched back, I'm not 100% sure in your case. But your breast density does change as you get older. So it's possible to go from a dense breast to a not so dense breast as you get older.
Within that 6-month period.
Not usually, no. Not usually, no. But it's also, again, it's an imperfect system. So yes, we have the BI-RADS, and yes, we have the ways to clarify or characterize your breast density, but some of it has a little bit of a subjectivity to it, and so it also depends on who's looking at it. Yeah.
What if you get knee and hip replacements?
And so it depends on when you've had them. The newer replacements are MRI compatible, so it's okay. The older ones are not MRI compatible. And so if we can't do it, we can't do it. I mean, the other part to that too is, like I said, you're down, like you saw from that picture, the way that you're sitting. And so sometimes people will complain that it's some pressure on their knee. And so, if the positioning doesn't work, then by all means, we just don't get it. So it is what it is. Yeah.
This is a record from the left, but now I have 2 biopsies. The doctor, they are not very conclusive. So in European, they have to do they recommended another mammogram. They already have 2 biopsies.
So an MRI might be helpful.
So MRI is the next step.
That would probably be more helpful. Because if you got an MRI and the MRI was completely negative or benign, then you could feel comfortable that those 2 biopsies were accurate and not worry about it as much.
And then for time, if we can just save questions.
I started it.
You got such good information and everything. We'll have time afterwards, I promise.
I'm sorry. Well, I told them they could ask me to interrupt me. Okay, so biopsy. So again, let's say, so they see something on the screening mammogram, you go in for your diagnostic, they say, yes, there's a mass there, we need to do a biopsy. So options for doing the biopsy, we have, if the lesion is seen on an ultrasound, we do what's called an ultrasound guided biopsy. So they use the ultrasound machine to find where the mass is and watch the needle go into the mass. If the lesion is only seen on a mammogram machine, then that's what's called a stereotactic biopsy. So they use the mammogram machine to do the biopsy. And then likewise, if you have a lesion that's only seen on the MRI, then we have the ability to do an MRI guided biopsy. There's also what we call an excisional or a surgical biopsy. So that's where we just go to the operating room and remove the area, but that's the last resort in terms of the biopsy. We like to know what we're dealing with before we go to the OR. Okay, so you get a biopsy and then you get results back. I like this picture because it kind of shows continuum of how things work. So what I always like to say in my clinic is that this is a basic cartoon of what a breast looks like. The breast, that we have two main structures in our breast. So sort of the stuff that looks like cotton candy, those are what are called lobules. And then lobules are connected to each other and then connected to the nipple through ducts. And so those are the two most common places we see breast cancer starting from. And you see on the very, very top of the picture, that's what a normal duct looks like. So a normal duct is a hollow tube. So you have a lining around the outside, you have a single layer of cells per that lining, and then usually nothing in the middle. Sometimes we can get what's called hyperplasia. So that's the second picture. So hyperplasia is where you have more than one cell per that lining, but those cells all look totally normal. Hyperplasia is a very common thing. It does not increase your risk of getting breast cancer. The third picture down, now you have an extra layer of cells per that lining, but those cells now look very abnormal. That is what we call atypical ductal hyperplasia. Again, same thing, that's not a cancer, but it is a marker for an increased risk of getting cancer. So it's somebody who has atypical ductal hyperplasia on a biopsy, that does increase your risk for getting breast cancer down the road. If those abnormal cells continue to proliferate and fill the entire duct, then it becomes a non-invasive cancer. So the fourth picture down, you'll see it says ductal carcinoma in situ. So that's a non-invasive cancer. The other way we call it is DCIS. So, and again, it just means that the cancer cells are all contained within the duct itself. If the cells break out of the lining of the duct, that's when it becomes an invasive cancer. Invasive cancers have the ability to leave your breast, whereas the non-invasive cancer doesn't. But for the most part, we treat both of them the same. As far as the invasive cancers go, the two most common invasive cancers that we see are invasive ductal, and then, we'll talk about DCIS, and then I'll talk about that. So DCIS. So again, this is the non-invasive cancer. How it usually presents is with microcalcifications on the mammogram. So again, that's the importance of getting a mammogram, is because if we see calcifications, it can push us towards needing to biopsy at something. There's a lot of controversy in terms of, is DCIS cancer or is it just a precancerous lesion? The problem is, and why it gets treated like a cancer, is that the thought is that if you didn't do anything, so if you just left this in the breast and you didn't remove it, there's about a 25 to 50% chance that it can become an invasive cancer. So that's why we usually still talk about it like a cancer and treat it like a cancer. But again, just know that there's lots of national debates about, is it really cancer or not? And most of the debates go along with what's called low-grade DCIS. So the nuclear grade is what the cells look like under the microscope, and so they get classified as either low, intermediate, or high grade. The low grade means that the cells don't look very different from normal. High grade means that they do look very different. And so the low grade DCIS is the one that the debates are usually about, in terms of saying that that's not really cancer, as opposed to the high grade. Most of the time, if you have high grade DCIS, there's not a lot of controversy about that. We treat that like cancer, talk about it like cancer, and treat it like cancer. Does that make sense? Okay, so that's DCIS. And so again, now going back to what I was trying to say before, so as far as the invasive cancers, so the two most common invasive cancers that we see are invasive ductal and invasive lobular. Invasive lobular, and it just depends on where the cancer formed. So ductal cancer, invasive ductal cancer has formed within the duct, whereas invasive lobular cancer has formed within the lobular tissue. There's good things and bad things about invasive lobular. So in general, lobular cancers tend to be more slow-growing, indolent breast cancers. The not so great part about lobular cancer is that they're very tricky. So they do this what's called single file lining thing. So you have the main mass, and then you have these tentacles that come out from it. And so because of that, it doesn't show up all that fantastic on mammogram or MRI. It ends up being a lot bigger than what you think it is based off of the imaging, and it's less responsive to chemo. So it's tricky. It's a tricky cancer. The prognostic factors, so the things that we look at. So again, if I'm seeing a patient in clinic with a new diagnosis of breast cancer, and I'm looking at their pathology report, the stuff that I look at are, one, the size of the tumor, not the size on the pathology report, but the size in the imaging. So the size of the tumor, whether it looks like their lymph nodes are involved, the grade, like we said, has to do with what it looks like under the microscope. So low grade is a grade 1, high grade is a grade 3. We also look at the receptor status. So the idea is there's, for invasive cancers, there's 3 receptors that we look at. We look at an estrogen receptor, progesterone receptor, and a HER2 receptor. So the idea is that we're looking for targets that we can go after to help us in terms of treatment. So if a cancer is positive for the estrogen receptor, it means that it's sensitive to estrogen. If it's positive for the HER2 receptor, then we know that we have ways to treat it by targeting that HER2 receptor. HER2 is a little bit confusing because like estrogen's easy to understand because it's a hormone, but HER2 is it's a growth factor, so it's a little bit harder to understand. Ideally, we like cancers to be estrogen and progesterone positive because it gives us a medical way of treating you. So with the hormone blocker, which we'll talk about, HER2 positive cancers tend to be more aggressive cancers. So ideally, we like it to be HER2 negative. But again, if it's HER2 positive, we have lots of really good ways of treating it. And then the last thing that we look at is the proliferation rate. So we call this the KI or the key, depending on who you talk to, KI or key 67. And this is the proliferation rate. So it's looking at what percentage of cells are actively dividing or in active mitosis. So it gives us an idea of the aggressiveness of the cancer, how fast it's growing. So if that number is high, then we know that it's a more active cancer. If that number is low, then that's a good thing. So treatment. So when we talk about treatment, I sort of break it down into 2 general categories. So we have local treatment, which is mainly treating the breast, and then you have systemic treatment, which is treating your whole body. So the local treatment is going to be surgery and radiation. The systemic or whole body treatment is going to be chemotherapy and endocrine therapy. So endocrine therapy is just a fancy way of saying the hormone blocker, essentially, or the estrogen blocker, however you want to talk about it. For surgery, it used to be that we would do these huge surgeries. So this is what's called a radical mastectomy. And so with a radical mastectomy, what they used to do is they would not only take the breast, but they would take as much skin as they could. Sometimes they would end up with skin grafts. That's how much skin they would take. So they'd take a ton of skin. They would take the muscle underneath the breast, and they would take all of the lymph nodes underneath the breast and underneath the muscle. And what ended up happening is the pictures on the bottom. So you can see one, there's a lot of disfigurement associated with that surgery. The other is that, there was a really high risk of getting lymphedema or swelling in your arms. When you see those pictures of those women with the big elephant arms, that's most of the time they had this procedure done. And then the third was that even though we were doing these huge surgeries, the cancer was still coming back. And so what we have learned is that bigger doesn't necessarily mean better, that unfortunately breast cancer is somewhat more of a systemic disease, and doing this big, huge surgery is not enough to make it go away 100%. So because of that, that's where we came up with what's called breast conservation. So breast conservation is the other name for that is a lumpectomy. So instead of doing a mastectomy where we remove the whole breast, we have the ability to do a lumpectomy and just remove the area where the cancer is sitting. Again, the term breast conservation generally includes radiation with that as well. So when we talk about breast conservation, most of the time it's a lumpectomy plus radiation. The good news is that there's no difference for the most part between the 2 options. So if you compare a lumpectomy plus radiation to a mastectomy, there's no difference in survival. Women that have similar cancers are going to live the same regardless of which of those options they pick. The other thing we look at is what's called local recurrence. So local recurrence is the cancer coming back in your breast or like on your chest wall or your breast or in your lymph nodes after the surgery. And you'll see, yes, there's percentage-wise, there's a little bit of a difference, but 2 things. One, that's over like a 20-year time frame, so that 2%, a 2 or 3% difference is not statistically significant over a long period of time. The other is that those numbers are a little outdated. So the more recent studies have shown that those numbers are actually a lot lower, or somewhat lower than that. So the biggest sort of take home of this.
It's turned off.
Oh, jeez. It's okay. It's okay.
Ones that break through
Of
no
course,
matter what.
of course. So it was a good distraction. So the sort of one of my take home points that I like to talk about in terms of this talk is that, again, there's really no difference between the two options. So I see a lot of patients who get diagnosed with breast cancer. They come into my office and their first instinct is to just remove everything. So the thought is, I have a tumor in my breast. You take my breast off, I'm done. I'm never going to have to deal with this again. That's not the case. So even with the mastectomy, there's still a chance the cancer can come back. By adding radiation to a lumpectomy, we can make that risk the same between the two options. So, the nice thing is you have options in terms of what we do. And again, you're going to hear varying degrees. You're going to hear different things from different people. My philosophy is that it's a very personal decision. And so even though the surgery, like the numbers are the same, there's lots of reasons why women choose to do mastectomies or choose to do lumpectomies. It's a very personal decision. And then the whole idea, again, of the radiation and the hormone blocker is that once we get it out, we want to make sure it stays out and doesn't come back. And so that's the idea of adding the radiation and adding the hormone blocker on top of the surgery. So the surgery by itself is not enough. That's why we add everything to it. Okay, so contraindications, and most of these are relative contraindications. The only really, really true contraindication to doing a lumpectomy is inflammatory breast cancer. And I'm sorry, I don't have any slides that talk more about inflammatory breast cancer. But what I can tell you is that it's a bad cancer. So inflammatory breast cancer is very rare, but it's a very aggressive cancer. And what happens is that you get what's called dermal lymphatic invasion. So you get the cancer cells are actually within the skin itself. So you get the skin is red, you get a lot of pitting and edema within the skin itself. Like I said, it's very rare. It's the chances of us seeing it are less than 1%. So it's a super, super rare cancer. But because the cancer cells are in the skin, a lumpectomy is not the best option for that. The rest of this stuff on there are relative contraindications. So what multicentric means is that when we talk about a breast, we divide the breast into 4 quadrants. And so multicentric means that you have 2 cancers in 2 different quadrants. So the idea was that, if you have a cancer up here and a cancer down there, you had to have a mastectomy. But in reality, a lot of times depending on patient preference and whatnot, sometimes we can do 2 separate lumpectomies and just follow that up with radiation. So that's what multicentric is. Anytime we do surgery, we want to get negative margins. And then the small breast to tumor size ratio. So the idea is that if you have, somebody who's got an A cup breast and a 5 centimeter tumor, if I did a lumpectomy, I'm pretty much removing the whole breast. So that kind of doesn't make a lot of sense either. And then it used to be, again, this inability to receive radiation, but that's changing. So again, that's sort of a relative contraindication, not a hard contraindication. These are not my patients. These are just pictures that I found. So it's not anybody that you know. And they're not necessarily the best pictures either. But the whole idea is just to go over in terms of mastectomy. So when we talk about mastectomy, it depends on if somebody's getting reconstruction or not. So if somebody's not getting reconstruction, we take the breast, we take the skin, we take the nipple, and try and get things flat against the chest wall. That's not super flat, but you get the idea. And so that's without reconstruction. When we do reconstruction, there's 2 options. One's called skin sparing, which is on the bottom. So that's where we still take the nipple, but we're leaving the nipple and the breast tissue, but we're leaving some of the skin to keep the outer envelope of the breast. And then we also have what's called nipple sparing, which is where we save the nipple. So we just make the incision, we remove the breast tissue from underneath the skin, we leave the skin and the nipple all intact. Skin sparing, nipple sparing mastectomies, they're safe. It's okay to leave the nipple as long as the nipple's not involved. And it is possible to get reconstruction. It gets, again, that's a whole nother can of worms. It gets very complicated in terms of the reconstruction, but the idea is that it is available and it is out there as an option. But there's lots of factors that go into somebody getting it versus not getting it. And then when we do talk about reconstruction, there's 2 ways that we talk about it. So one is an implant-based reconstruction. So that's where predominantly they're using silicone. So they use silicone or saline implants. And then we also have what's called a tissue-based reconstruction. Sort of the standard way that we do that nowadays is what's called the DIEP flap or deep flap. So it stands for deep inferior epigastric perforator flap. So the idea is they're taking fat from your stomach to recreate your breast. It's nice. So you get a tummy tuck out of it, but it's a really big surgery, and it looks fantastic, but it's a really big surgery. And because you can kind of tell, so like this in this picture, there's one breast with an implant and one breast, a natural breast. And so even in a small-breasted woman, it's very hard, and it's even harder in a large-breasted woman, but it's very hard to make a reconstructed breast look like a natural breast. And so the deep flap is a way allows us to do that a little bit better because you're replacing fat with fat instead of using an implant. But like I said, it's a much bigger process, and we can talk some more about that if anyone has any questions. But just because I know we're running out a little low on time, so I just you tell me when to stop. I'm good to go. Okay. So lymph node removal. So just to talk a teeny bit about this. So the idea is that if the cancer were to leave the breast, the first place it would go is the lymph nodes underneath your arm, and then from there it could go to other places. And so at the time of surgery, we generally remove a couple of lymph nodes. We look for the lymph nodes that drain the breast first, because again, that's the first stop that the cancer would go. And that's what we call a sentinel lymph node biopsy or excision. So yes, the word biopsy is a little bit of a misnomer because we're not sticking a needle in it. We're actually removing the whole lymph node. But the idea is that, we used to, again, when we talk about these radical mastectomies, used to take all the lymph nodes that were underneath the arm, and that's not, we don't do that very much anymore. Sometimes we still have to, but so the idea is that by looking for the lymph nodes that drain the breast first, it's faster, there's less complications because I'm taking out less lymph nodes, and it's still fairly accurate in terms of painting a picture of the rest of the lymph nodes. And so usually what happens is there's a couple things that get injected underneath the nipple while you're in the operating room, and that shows the surgeon the drainage pattern so they know what to take out. And then, so reasons why we do sentinel node biopsies, this is changing. So it used to be that anytime somebody had an invasive cancer, we would do a sentinel node. But there have been recent studies that have shown, women over the age of 65 with a small, not very aggressive cancer, the chances of it having gone to the lymph nodes are very, very small. And so why put them through that? So there are instances where we don't do lymph node excisions for invasive cancer. But again, it's one of those things that it's a conversation with your surgeon to see what the best thing to do is. Let's see. Okay, so that was the surgery part. And so, like I said, so surgery, so the two options are the lumpectomy and the mastectomy. And with the lumpectomy, a lot of times we add radiation. So I just wanted to touch on that a little bit. So for the radiation, like I said, the reasons to do it are going to be after somebody's had a lumpectomy. Again, not all of the time, but a lot of the times we do it. After somebody has had a mastectomy, sometimes we'll do it for close margins or a tumor bigger than 5 centimeters or positive lymph nodes. And then we also tend to do it, again, like we talked about in the inflammatory breast cancers, usually patients will get radiation whether they had a lumpectomy or a mastectomy, or I guess I already said they don't get lumpectomies, but they usually get radiation after the mastectomy. And then if we have a recurrence, sometimes you'll get radiated after that as well. That's sort of what the machine looks like, again, just so that you guys can see it. Radiation has a sort of stigma to it. You tell somebody they need radiation and it sounds super scary, but most people do really, really well with it. There's two forms of radiation that we use. So one is what's called whole breast radiation. So that's where the entire breast gets radiated. So it's all of the breast tissue. The sort of standard used to be 5 days a week for about 6 weeks. We now do what's called hypofractionated radiation, which is where you do 5 days a week for 4 weeks instead of 6 weeks. But we also have what's called accelerated whole breast, which is where they do the whole breast, but they just do it in 5 doses and that's it. So that's a possibility now as well, and that's a newer technique over the last couple of years. And then we also have what's called partial breast, and partial breast is where they just radiate the cavity where the cancer is sitting instead of radiating the whole breast. There's also in some of your readings, you might come across intraoperative radiation. So it's possible to do radiation at the time of the lumpectomy. We don't have that in Tucson. We did it when I was at Banner, we did it for a brief period of time, but it was a trial and it's not there anymore. So we don't have an ability to do it in Tucson, but if that was something that somebody was interested in, I could always help them find a place to go to do that. But again, you can kind of see what the machine looks like. And so usually the treatment wise, you're laying on the table, arms above your head, that part up on the top kind of goes, back and forth. It's like a picture. You don't see anything, you don't feel anything. You're laying down for 10 minutes, you get up, you walk out. Yes, you got to do that 5 days a week, but it's fairly well tolerated for the most part. The main side effects are going to be skin changes. So it's like a sunburn. So you get some redness and some peeling of the skin. It's not permanent. It goes away. And then fatigue. That's a really big one. So people just feel really tired and really run down in general. But it's not the same as if you've had chemo. It's a lot better than that. Okay, so that's radiation. And then in terms of, and so again, we were talking about local. So local therapy is surgery and the radiation. When we talk about systemic therapy, that's the whole body. And so when we talk about systemic therapy, it's chemotherapy and the estrogen blocker. The chemotherapy is based off of the behavior of the cancer. So if somebody has an aggressive so we talk about giving chemo to people if they have an aggressive cancer, and it doesn't depend on what surgery we do. So if somebody has an aggressive cancer, they're going to need chemo regardless of whether we do a mastectomy or a lumpectomy, okay? And so some indications, so when we talk about a triple negative breast cancer, that's when the estrogen, the progesterone, and the HER2 receptor are all negative. So that's an aggressive form of cancer. Like I said before, the HER2 positive breast cancers are more aggressive in general. So those are two very strong indications for somebody getting chemo. If somebody has a lot of lymph nodes involved, sometimes the oncologist will talk with them about doing chemo. And then we also have what's called there's a couple different versions of this, but you'll hear Oncotype DX, and then the other thing you'll hear is a mamma print. And so what these are, they're what we call gene assays. So the idea is that a piece of the cancer gets sent to a company and they do a special gene test on the cancer. So it gives us more specific information about that particular cancer. And so instead of, what's the word I'm looking for? Instead of, because again, every breast cancer is different. So instead of sort of clumping every breast cancer together, it gives us the ability to get more information about that specific breast cancer so that we could treat it a little bit better. And so what the Oncotype and the mamma print do is it gives the oncologist an idea of how much somebody would benefit from chemo. So the idea is if that number is high, like if it's a high number with an Oncotype or it's what we call high risk with a mamma print, then there is benefit from doing chemotherapy, and that's when they would recommend it, okay? So again, in the journey, in treatment, you'll hear either Oncotype or mamma print. Oncotype tends to be the more common one used, so that's usually the one you'll hear the most about. And then that's just some examples of some typical breast cancer regimens for the chemo. Again, with the HER2 positive drugs, we have medications that are specifically targeted to the HER2 receptor and work very well. And then there's always new things that are coming out. So we now, within the last couple of years, have what are called CDK4 inhibitors. The two that you'll hear the most about are Verzenio and Kisqali. So there's, commercials for Kisqali all the time. But the idea is that it inhibits one of the growth pathways of the tumor cell. And so it's not chemo. It doesn't have the same side effects as chemo. It still has some side effects, but not the same as chemo. But it's another oral drug that the oncologist now has to add to women who have more advanced cancers that would benefit from it. And timing wise, again, it gets a little bit confusing because if somebody needs chemo, sometimes we talk about doing it before surgery. Sometimes we talk about doing it after surgery. The benefits, so when we talk about doing it before surgery, is what we call neoadjuvant chemotherapy or neoadjuvant systemic therapy. And so the benefit of doing it beforehand is that it allows us to be able to see how well the tumor responds to what we're giving you. So if you have a tumor in your breast and we're giving you chemo, then we can make sure that we can see that the chemo is working. The other is that it can potentially change what surgery we do. So if you have somebody, again, who has a small breast and has a really big tumor, if we did some type of medicine before the surgery, we could shrink it and make them a better candidate for a lumpectomy. And then in some instances, we have what's called a complete pathologic response. So what that means is that if somebody gets chemo before surgery, we then go to the operating room, and on the final pathology, the cancer's gone. So the chemo killed all of it. That's what we call a complete pathologic response. And that's a very good sign. So it's associated with a better prognosis. It gives us a little bit more information about how well the tumor responded to everything. Endocrine therapy, that's the I don't know what the right word is, everybody's favorite, right? So the endocrine therapy, that's the hormone blocker. And the whole idea is, again, that if you have an estrogen sensitive cancer, then it means that the cancer is using estrogen as part of their growth mechanism. It's not the only thing that they're using. Like we talked about before, it doesn't mean that you have a lot of estrogen in your body. It's just one of the many growth pathways that we actually know about. And so we can stop that. So we can stop it in two ways. One is with a drug called tamoxifen. So tamoxifen is an estrogen receptor blocker. So it sits in the estrogen receptor and turns it off. That's the oldest drug that we have. So that was the first one that came out. And so it used to be that everybody got it, but now it's predominantly used in premenopausal patients because, again, it's not touching the estrogen coming from your ovary. It's just sitting in the receptors and turning them off. For postmenopausal women, we use what's called aromatase inhibitors. And so what that does is it stops the formation of estrogen. It stops what we call the peripheral conversion of estrogen. And so that's the drugs you'll hear about: letrozole, anastrozole, and exemestane. Generally, again, this is recommended in an estrogen-sensitive cancer. We know it works. It can decrease the risk of the cancer coming back by about 50%. Generally, it's recommended for about 5 to 10 years after the surgery and after the radiation. But there are side effects associated with it. And that's why I say that it's everybody's favorite, because most people who take it hate it. But again, it works, and you just have to remember why you're taking it. What I always like to tell patients in clinic is that everybody's different. I do have patients who take it who have absolutely no side effects whatsoever. I have other patients who take it who have a million side effects. We don't know where you'll fall on that until you start taking it. And we do, because we've been using this drug for a while, we have good tricks to help with some of the side effects. In terms of if they do happen. And so side effects in terms of what we see, so the things that we hear the most about are menopause, return of menopause symptoms, so hot flashes, night sweats, and vaginal dryness. And then the other big one is joint pain, so just feeling like you're stiffer and achier, especially in the morning. So that is a whirlwind tour of breast cancer treatment. I know it's a lot of information. Again, my one of my other take-home messages is that there's options. So, it used to be you had breast cancer, you did A, B, and C, and it's not that way anymore. So we are very good at individualizing care. I know especially myself and my take into account the patient and the patient's desires and wants and all that stuff. So we are able to individualize care. It's very important to advocate for yourself. Like you said, be what did you call it? Squeaky wheel. Be the squeaky wheel. So, again, it's hard to do research because there's so much stuff out there, but we're not in a time anymore where, it used to be you go see a doctor and the doctor told you to do something and you did it. And it's not like that anymore. So, you have the ability to question and make sure that you're getting the appropriate care. And then find your team. So, it takes a village. There's a ton of us who treat breast cancer. From the surgeon, the medical oncologist, the radiation oncologist, all the staff in the clinic. We have nurse navigators, we have patient advocates, we have nutritionists, lymphedema specialists, all this stuff. So it's a village. We know it's a village, but that's what we're here for. So you guys need anything, you make sure that you have a team who will listen to you and help you.
And when I talk to women that have cancer, I talk about that as an option. The surgeon who did my DEEP is no longer in town. Is that something you might feel comfortable with sharing the name of the surgeon that does, so I can get it out?
Yes.
What's the DEEP?
So the DEEP was that deep inferior epigastric perforator flap. So that was where they took the fat from your stomach to recreate the breast. So there, and it's changing. It used to be, so Dr. Mahavir and Dr. Kurtovic are plastic surgeons who do the deep flap. It's Mahavir, Mahabir. So it's Tucson Plastic Surgery. The caveat with that is that they don't take all insurances. And they only do it once, they only do them on Fridays. So sometimes we don't do it at the same time as the mastectomy. Dr. James Ruff is another plastic surgeon in town who has also started doing them. Again, same thing, doesn't take all the insurances. I don't know, do you know, is there somebody at Banner doing it, Maya? Not sure.
I don't know. I mean, there are some good surgeons also in Phoenix. So
yes,
I'm not
that was my next thing. So there's names of surgeons that we can give you that are up in Phoenix as well. Yeah. And the deep flap, it's a really good option, and you can attest to that. Like,
I mean, if somebody wants to see my
I love it. I know, I love it. But it is a big process. It is a very big process. No, it is not.
Yeah, so I've got a couple of questions, Dr. Viscusi, that came in online. I'd like to go ahead if we can, if I can go ahead and get them answered. One was about tamoxifen.
Yes.
So somebody who's been on it for 5 years, sort of as a preventative measure. So I guess high risk of breast cancer, but not diagnosed, doesn't have BRCA. And mentioned a higher Gale score rating. And I'm not certain if you can cover what a Gale score rating would be.
Sure.
But is something that people take as far as sort of a preventative measure?
Yeah, it's possible. So the question was tamoxifen. Again, that was the estrogen receptor blocker. Sometimes it can be used for prophylaxis in women who are at a high risk for getting breast cancer. So there's a couple risk calculators that you can do, which give us a rough estimate as to somebody's lifetime risk of getting breast cancer. So the Gale model is one, and there's also what's called the Tyrer-Cuzick score, and then BRCA Pro, and there's something else. Again, there's advantages and disadvantages to all of that. So the idea is that if you have an elevated lifetime risk of developing breast cancer, you're at a high risk, and that we may consider doing tamoxifen for prophylaxis. Again, just like with somebody who has breast cancer, the advantages is that we know it works. It can decrease your lifetime risk. The disadvantages is that it has side effects. That being said, in the prophylactic world, there has been recent data that has shown that you can do low dose tamoxifen, like 5 milligrams of tamoxifen for 3 years instead of 5 years. And that's also somewhat protective. And there's less side effects with that. Again, that's not for somebody who already has a diagnosis of breast cancer.
Okay, great. Thank you. And if you have, you've talked about dense breast tissue. Does that impact your risk of cancer as well?
Yeah, yes. So the studies have shown that having dense breast tissue does put you at a higher risk, but I think it's just because you have more, how do I want to say this? Like the reason why somebody has denser breasts is that they tend to have less fat in their breast and more of what we call the breast parenchyma or the breast tissue. So if you have a denser breast, you have more breast tissue per se. That's not exactly 100% correct, but and so it does put you at a little bit of a higher risk. But again, that's not necessarily something you can change. And it's not a high enough risk that I would say if they told you had dense breast tissue on a mammogram that you should go out and get a double mastectomy.
Okay, fair enough. I also let's just tell everybody where you're located. You're right here on the campus.
Yes.
Right.
Yes.
So I wanted to also share your phone number. So if anybody is interested in an appointment, they can certainly call 520-420-2500. You are just north of the main TMC Health campus in the TMC for Women building, right?
Yes.
Right next to the Catalina Garage. If anyone is interested, that's just off of Craycroft. So just so that they know where that is, they know how to give you a call as well. I'm going to wrap up with our online audience. I want to thank you so much. you brought up, there were so many questions that we have so many other topics that we're going to have to cover. So thank you so much, Dr. Viscusi. I'll turn it over to you for any other questions. Thank you so much. Take care. Thanks again for being here today. We look forward to seeing you back. We actually have 2 more talks that are all related to our survivorship series. The next one is called The Facets of Grief and Loss After Diagnosis. That's going to be on Thursday, October 23rd at 10 a.m. And then the last one this month will be Cognitive Healing and Fatigue. And that one is Wednesday, October 29th at 2 p.m. If you're interested in either of these talks, please give us a call. The phone number is 520-324-1960. Thanks so much for being here. We'll see you again soon.